First, I'm just going to tell you about what I'm going to talk about. So the talk's really going to be divided into 4 parts. The biggest one is, would someone benefit from a liver transplant? Because if you're not going to benefit from a liver transplant, then that can actually cause more harm. Once we've answered that question, we'll talk about the wait time. Then, what would you expect after you get a liver transplant? And then, I think for this group, really, will autoimmune hepatitis recur? So, reasons for a liver transplant. So, many of you in the audience may be aware of sort of what the symptoms of chronic liver failure can be. And they're sort of in a few different categories. So we have portal hypertension. So this is usually where, if I'm sitting with patients in the office, I like to draw pictures. I don't have that opportunity right now. But portal hypertension is what happens when blood has a hard time getting through the liver and has to sort of find other ways around the liver. And as a result of portal hypertension, you can get bleeding varices. You can get varices in the esophagus. Those can bleed. And also ascites. That's the fluid in the belly. Jaundice. Now, jaundice can occur in acute autoimmune hepatitis, and some of you in the audience may have had jaundice as one of your presenting symptoms. But autoimmune hepatitis actually, it can be treated and the jaundice can go away. But if the jaundice doesn't go away, this is one of the things that can suggest that the liver disease is more advanced. Encephalopathy, it's a fancy way of saying confusion. And this is when it's sort of the body's response to portal hypertension is by making new blood vessels that don't go through the liver, where the blood doesn't go through the liver, and it can lead to confusion when that blood passes through to the brain. Coagulopathy, this is indicated by, it's a blood measure that your doctors may have checked called the INR. It tells you how thick or thin your blood is. Anytime anyone with cirrhosis is at risk for liver cancer, so that's hepatocellular carcinoma is the more common one. And then worsening kidney function, usually in the setting of ascites, can cause something called hepatorenal syndrome. So any of these, to a certain extent. So if someone has one of these, that's usually not enough that would indicate needing a liver transplant, but a sort of a bulk of these, and there's scoring systems that we use in the clinic, would indicate that a liver transplant might be relevant. So if your doctor deems that you might be sort of a candidate for a liver transplant, this is sort of the way we do it at our institution is a patient's referred, and then we have an evaluation day where you meet everyone from the team. You meet the transplant hepatologist. Sometimes it may be your own hepatologist or gastroenterologist that you're seeing that's part of a team. It might be a new one. There's surgeons. There's a whole bunch of labs, and then everyone gets to see a cardiologist to make sure their heart would be okay for the surgery. We meet every week to discuss whether patients are candidates for a liver transplant or not. Very few actually are not candidates. Usually we screen at the referral stage before. And then there's a whole bunch of testing that happens afterwards. And all this testing that's done after the initial evaluation is to see whether there's any contraindications to doing a liver transplant. So what does that mean? Are there any things that would make it so that a liver transplant would actually be a bad thing as opposed to a good thing? And then once everything is all said and done, a patient can be listed, and I'll go over what that entails as well. So this is to show you that it's a huge team effort. It's not just led by really one person. So patients, this should be you plus their caregivers and the family, because it takes a lot of people to get someone through a liver transplant. So here, this would be my role as a transplant hepatologist. We also have the surgeons. Medical assistants are important to get labs all the time. We have a nutritionist who works with you, because when patients have end-stage liver disease, there can also be a significant amount of malnutrition associated with it. We have a financial coordinator. A liver transplant can be very expensive, and so we make sure that you have enough insurance in order to get you through the surgery itself, and then afterwards, if it's needed, a transplant psychiatrist. And particularly in autoimmune hepatitis, this isn't actually as much of an issue, but for our patients with history of substance abuse, this is actually a bigger thing, but it can be an autoimmune hepatitis. We have a social worker who can help out too, and a coordinator who is sort of tells each of these people what their role needs to be at this time. So I would actually say the coordinator is probably the most important person in this case. Contraindications. So if someone has liver disease and they have those indications that I talked to you about first, if they have any of these other things, then a liver transplant could actually be worse for them. So severe heart disease or lung disease. So if a patient has either of these conditions, it may be, the postoperative period may actually be very difficult. Cancer within 5 years. So if someone has a cancer that's been diagnosed within the previous 5 years, and we're not sure if the patient is cured of their cancer. So actually breast cancer and prostate cancer are sort of excluded, but something like colon cancer, pancreatic cancer. The reason being is that the immunosuppression that's given afterwards, so it's very similar to the immunosuppression that's given pre-transplant for autoimmune hepatitis, but it's a little bit more intense. Tends to be less prednisone, but sort of more intense medications. If there's an uncontrolled medical problem, that would not improve with a liver transplant. So this is sort of a grab bag way of saying if there's another medical problem that would make it so that after liver transplant, the patient would be doing much worse, then that would be a contraindication for liver transplant. An example of this might be uncontrolled sickle cell disease. So it's sort of a controversy right now among our field, but if someone needs a liver transplant but they have sickle cell disease, those patients can do very poorly afterwards because they can get blood clotting that would then make it difficult for the liver to continue. If a patient doesn't have health insurance, and this is more of a problem of the United States than typically in other countries. Anyone here from Canada in this room now? So my Canadian colleagues sort of laugh at me because this is not an issue that they have in Canada for liver transplant. And social instability. So, and this is sort of another grab bag way of saying, it's important that there's a sort of a social network that the patient has, and also that they're sort of in a stable living situation. How are organs allocated? And we were just actually discussing this up here at the front of the room before the talk. But they're mainly allocated on blood type. So the blood type has to match. There's just 4 blood types, A, B, AB, and O. So those blood types have to match and be compatible. Actually, they don't have to match. They just have to be compatible. And we can talk about that later if you guys have questions. There's something called a Meld score, and I'll get into that. And you guys may have heard of this score before. Your doctors may have talked to you about this, what this Meld score is. And then how far the transplant center is from the donor hospital, and then if those things are all the same, then how long someone's been on the wait list. So this is unlike the kidney transplant waiting list, is where time on the wait list is really important. But for liver, it's done a little bit differently, this Meld score. So, all right. You get through all the stuff. How long do you have to wait? And this varies. It has to do with this thing called the Meld score. Raise your hand if you guys heard this term before. Okay, great. So what is this? And your doctors may have talked to you about this. So it's a measurement in how severe your liver disease is. And it's not a perfect score. And there's certain populations that are actually disadvantaged by the Meld score. But if you look at a large population of patients, you can see that patients who have higher Meld scores, it portends that their likelihood of dying soon, or dying in 3 to 6 months, is much higher than patients with a low Meld score. And it's composed of 4 different lab values that we can get. What's nice about this is it's very objective. So in the pre-Meld era, there used to be some subjectivity to the scores, and because we all wanted to advocate for our patients, we would give you the highest score, which was nice, but people were sort of playing the system. So now, a creatinine in Philadelphia would be the same as a creatinine in Indiana. So this score doesn't change no matter where you move in the country. And later we can talk about, where people get transplanted actually can change, and this is actually in the news a lot. So creatinine, bilirubin, sodium, and INR, and your score can go from a 6 to a 40. So in general, depending on where you are in the country, the average Meld score for a transplant can differ. In Indiana, I guess Craig just left. I think it's somewhere in the high 20s. Where I live, it's around 30. Where these guys live in New York, it's probably 31, 32. So it's not it's the best system we have so far, but it's still not a completely fair system. So there's actually a federal court case going on right now trying to figure out how can we make liver transplant allocation more fair. But I feel like it's a little bit beyond this talk, but I'm happy to talk to you guys about it afterwards later. There is something called living donor liver transplant, and you guys have probably heard something about how the liver can regenerate better than any organ in the human body. And so we use that to our advantage, and for patients who, I'll talk to you about living donation. So you don't have to your Meld score doesn't have to get very high. If you meet these indications for needing a liver transplant, and you have someone who would be a match, it's usually it's most often I see adult children donating to their parents, or parents donating to their kids. And the recipient can be anywhere from 21 to 65. Anything over 60, we sort of figure out whether that it would need a whole liver or a part of liver. And for the living donation, it's paid for by the recipient's insurance. So if you're a patient and you have someone who wants to donate, then the patient's insurance is the one who would provide it. It is a major surgery, but the recipient undergoes a much smaller incision than the recipient does. And most recipients can return to work, donors can return to work in 6 to 8 weeks. They need to have compatible blood type and good health. Really quick. And generally between the ages of 21 to 50, but other centers, our center and most centers will sort of around, if someone is 18 and they want to donate to their parents, sometimes we've done that. If they're 55 and they're in great health, a marathon runner, that sort of thing, then sometimes we'll do that too. Any questions so far about anything? Okay, great, I'll keep going. So being placed on the wait list, once someone is placed on the wait list, deemed that they need a liver transplant, the wait can vary. And again, it depends on the Meld score. And every week I get an email saying, like, this is our list, and these are the scores, and the scores can go up and down. And so depending on what someone's score is, they have to get recertified every 3 months or 1 month or even a week if they're very high scores. And during that time, you continue to meet with your doctor. Once a year, you might meet with the surgeon and meet with the social worker, make sure everything is okay. And that's sort of what I talked about there. What would you get a call. What do you expect a liver transplant? This is just, there we go. So here's a cirrhotic liver, and here we have a gallbladder and the bile duct. This is the portal vein and the hepatic artery. These are severed here, and then the new liver is then taken and sewed at each of these places, and these are called anastomoses. This is where actually some of the complications can occur after a transplant, is at these anastomoses, because you can imagine that, you look around the room, everyone is of slightly different sizes, and so the same thing can happen to the liver. You can have slightly different sized veins that are connecting up to the liver. The surgery does take yes, go ahead.
What number do you like to send people to the transplant team? What would be their Meld score that you would?
It varies. I usually do it more based on disease severity, based on symptoms as opposed to the score, but I take the score into account too. Generally, if someone has ascites that's not being managed well, or encephalopathy that's not being managed well, that's an indication for me to start an evaluation, even if the Meld score is low. The reason being, so that's why it's important to think about the symptoms. Like, if someone has very well-controlled symptoms from liver disease, they may not necessarily need to be evaluated for a transplant. Also, okay.
You had to, along with those things, you had to have a certain score, so you don't have to have a certain Meld score.
No, to undergo an evaluation, there's no limit on the score. It's to obtain the transplant, we're sort of at the whim of the waiting list. Yeah, but in general, if any of those symptoms are present, that's sort of a trigger to say, okay, it's time for an evaluation. And a lot of places have sort of a way of we have at Penn we have a waiting list. So we have a list of patients who have symptoms from chronic liver disease that if they get sicker, have had all the testing, and then can easily be put on the waiting list. And I think in most other centers do something similar. If this were an unlimited resource, it's something that we would be transplanting at much lower Meld scores. But because of the resource limited nature of how a liver transplant is obtained, we don't have enough livers for everyone who needs them.
Right. Yeah, because I'm going through something like that. I'm having, encephalopathy and kidney problems and stuff like that. So, Dr. Laren's looking at my Meld score, and I don't know too much about it.
Yeah, and it can vary, so week to week, depending on what the medications you're on. So what would you expect? So immediately after the surgery, you go to the ICU, and patients can be in the ICU from anywhere from a day. If there's complications, it can be much longer. Typically, if a patient is transplanted if someone's called in from home, they tend to be in the ICU less. If someone's been in the hospital for a while before the transplant, which can happen, they tend to be in the ICU longer. And during recovery, we want patients to get out of bed. You meet the whole team. The average stay is, I would say, between 1 to 2 weeks. It says 7 to 10 days, but it can vary depending on the age of the patient and how sick they were going into the transplant. And then afterwards, if you're seeing your doctor a lot before the transplant, you continue to see your doctor a lot after the transplant. A lot of the medications that someone is on before a transplant, they're not on any longer. They switch them for new ones. So long-term immunosuppression, which everyone in this room is familiar with, we use slightly different drugs. They're a little bit more immunosuppressant than most of the autoimmune hepatitis drugs that we use, and they can be fairly costly. So this is why it's really important that the insurance doesn't provide a problem for the patients to get these medications. We're seen at least weekly for the first month, and usually first 2 months, and then every 2 weeks, and then frequent labs. So we get labs almost every week for the first 6 months. And you can get rejection, and rejection is actually, it's sort of similar to, it's an immune reaction that happens in the liver. It's almost like autoimmune hepatitis, but the body is reacting to a liver that is not their own, so we call it rejection. And it's treatable. There's different medications we use if rejection occurs. So what are the other potential complications? There can be reoperation, bile duct problems, that's usually from the anastomosis, heart disease, high blood pressure, kidney dysfunction can actually happen as a result of tacrolimus, which is sort of the backbone. I'll get into that in a minute. Liver transplant outcomes. So autoimmune hepatitis, if someone gets transplanted for autoimmune hepatitis, they actually do about the same, if not better, than patients that are transplanted for NASH, non-alcoholic steatohepatitis, or alcoholic cirrhosis. So here, this is just the 10-year data. So you see about more than half, 61% of the grafts are surviving, and 65% of patients at 10 years with autoimmune hepatitis are still living. And this tends to be a group that if they're not getting a transplant, would not have anywhere close to this 10-year survival. So the outcomes, I'd say comparatively to other liver diseases, are very good, as good if not better. And then for those who like it in graphical, it's called a Kaplan-Meier curve. It's a curve we use a lot in medicine, but just shows that, so this is the time, this is in months, and this is the percent of survival, and you can see autoimmune hepatitis is doing much better. It's this dotted red line here than sort of the rest of the group. So patients with autoimmune hepatitis tend to do well after transplants compared to the rest of the group. All right. Sorry it took so long for me to get to this point. So will my autoimmune hepatitis return after a transplant? And the answer is it can, but it's not that common. So when looking through this talk, most of the studies actually looked at autoimmune hepatitis recurrence before tacrolimus. So tacrolimus is an immunosuppressant. In some cases, I use it for my patients with autoimmune hepatitis, but I try not to, because it's a really strong immunosuppressant. It can cause kidney damage, the levels need to be monitored, and in some cases, autoimmune hepatitis, it's really what we need in order to get a patient into remission. But for liver transplant, we use it in everyone. And it's the best immunosuppressant we have for keeping that liver in there without rejection, but it does cause long-term side effects. So most of the studies looking at autoimmune hepatitis recurrence occurred before tacrolimus was really used so much. The most recent study showed that maybe there was a 7% recurrence. So this is good. This says that we're really able to handle autoimmune hepatitis so it doesn't come back very frequently. And I think the reason being is the same medications that you'd use for autoimmune hepatitis are being used for liver transplant to keep that liver in. So, there's not much else that we would need to do. Unfortunately, a lot of patients with autoimmune hepatitis remain on prednisone after a transplant. And there is some controversy about this, and so that's why my next slide is actually, this was an article that came out last year. Lisa Foreman is at Colorado, and if you guys are interested, you can look through this paper, but they feel that whether you're on prednisone or not after a transplant for autoimmune hepatitis, it doesn't matter, it doesn't affect you. And so, because there's a thought that some people feel like, yes, you need that extra immunosuppression that you get with tacrolimus. Tacrolimus isn't enough, and some people say, well, it is. And what I would say is, it's really a case-by-case basis. In general, the way I practice with patients that get transplanted for autoimmune hepatitis is I lower the doses, and then if the enzymes start to go up, then I raise the doses. Similar to how I practice with autoimmune hepatitis, but we tend to get labs more frequently, and we tend to get levels more frequently. This is a controversy. I think we're going to start to see that more patients are even going off of prednisone, really on a case-by-case basis. But some of my colleagues feel that you always need to have a little bit of prednisone if someone gets transplanted for autoimmune hepatitis, but I don't know, I'm not convinced. So that's my slide, but I'm happy to answer questions about the topic or about anything else related to sort of the chronic liver failure or liver transplantation or post-transplant. Yes?
I saw on one of the slides where ages 65 and older are considered on a case-by-case basis. Does that mean you can't get on a transplant?
No, you can. It's the recipient.
Right.
No, actually, at my center, we've transplanted, I think the oldest patient we transplanted was 75.
So they can be on the list just
Yep. This is, every Monday afternoon we meet and talk about every patient, looking at all the different aspects. And it depends on, particularly for patients that are older than 65, it depends on their other, not as much on what's going on with the liver, but what's going on in the rest of the body. Oh.
You have listed conditions where you cannot receive a transplant,
Mm-hmm.
and lung disease was on there. What if you have early lung disease?
It's not a problem. It's severe. It's severe lung disease or severe heart disease. In some instances, we'll actually do more than one organ. So we actually, for autoimmune hepatitis is not typically one of them where patients require more than one organ. But if someone has kidney failure and liver failure at the same time, sometimes we'll do a kidney and a liver transplant at the same time, or a day apart. We do lung and liver too. We've done heart and liver.
Like for interstitial lung disease?
Mm-hmm.
Worse one than the other?
Yeah, no, we do. Typically, we do combined liver and lung in patients with cystic fibrosis. That's what we see most of, but we've done it in other diseases too when they're disparate. So, but it's the severe part that's the important. So, mild lung disease or even moderate lung disease is not a contraindication to getting liver transplant.
Let me ask you a question on that, because I have restricted lung disease. So where would that put me if I had a liver transplant?
So it would depend on the evaluation and sort of how much, I guess it can depend on how much lung function and what the pulmonologist who you're meeting with in the liver transplant center, if you needed a liver transplant, how they felt, whether they could get you through the surgery. Because the risk for heart disease and lung disease comes in the post-operative time and being on the ventilator and being on bypass.
Because I see that it's 8 to 10 hours,
Yeah.
so that could be a big issue for me.
Right. So it's something that would be discussed at, if you had to undergo a liver transplant evaluation, it would be discussed among the group looking at your file to see, how severe it is, and then the pulmonologist. Are there other medications that might be able to help you through it? So, at our center, we sort of, and I think Indiana is a similar situation. We'll look, at pretty much everyone and try to figure out, and if someone is deemed not a candidate, we still want to try to do whatever is best for them to try to get them through it.
I went through this journey about 2 years ago, and one of my big concerns is reoccurrence of autoimmune hepatitis. The 7% is pretty encouraging, because I've read it's in the 20s and even a little higher.
Yeah.
How does it manifest itself? Is it usually caught through the quarterly blood test that you do as a post-transplant patient, or are there outputs of?
No, it's usually just an elevation in the liver enzymes. So, if someone has had a liver transplant and they become jaundiced, then we're not doing our job of being able to monitor effectively. It's usually just an increase in the enzymes that we'll see.
I too had, this 2.5 years ago, but they've never said that AIH was recurring in me.
Mm-hmm.
They told me I had 4 rejections and
Yeah, and I will say it can be difficult sometimes to differentiate between rejection in autoimmune hepatitis or recurrence of autoimmune hepatitis because they can look similar. There are certain features on the biopsy that can say that it's more one than the other, but some of the features that we see on autoimmune hepatitis can be seen in rejection.
well, I was under the impression that although my transplant is done, you never get rid of AIH. I don't know why they would call it recurrent when it's not curable.
No, that's a good point. You could say,
The wording is a little off for me.
yeah.
Why would it be recurring when you technically cannot get rid of it, right?
Yeah, I mean, if you still have the antibodies in your system, you're right. But if you can think of a better word, I'm happy to use that instead.
I don't know. It's you. And they've never said to me, okay, your blood work is showing recurrence. They've always just said, okay, you're rejecting it.
Right. What I will say is the treatments tend to be similar, though.
Right, and they keep adjusting the tacro. And my prednisone has been on 11 years, but tacro I wasn't put on that until 10.
Right.
But they keep playing with it. All I can say, I guess the only good news about this is no new damage to the liver. So I just look at it as okay, I'll just recommend and that's it.
Yeah.
As long
No,
as I
that's
don't
good.
have to go through that again, I'm fine.
Okay. I think that, yes.
If you have varices that are abandoned,
Uh-huh.
what happens after you transplant to the liver?
You don't have to do that anymore.
I know, but is it damaged or scarred, or
No.
any problems with that at all?
Regarding the Meld story, you didn't touch on exception points. When you have an exception, what are the types?
The most common one is for hepatocellular carcinoma, liver cancer, but there's a slew of other sort of manifestations of liver disease that can be applied for. So lung disease is one. What was it? There's certain lung diseases that can help for exception points too. And we often have to write a story, and then we put it towards a board of doctors, and they look at it and they say whether it gets a thumbs up or thumbs down.
And they can feel it. Right?
Exactly.
Feels, and then my doctor feels it.
So you have to have a persistent doctor too,
Oh, yeah.
but it's not a guarantee if they try to get exception points that they can get it.
So if you check every so often on the MRI for cancer of the liver, and it comes up that you have liver cancer,
Mhm.
you go right on the list, or?
No, I feel like that. You can. I mean, you could talk with your doctor about that, but there's also there's this whole other sort of set of rules on how many points you get, when you get the points, and that's also something that's changed, I think, this month, or last month. It's June now.
Changed nationally or?
It changed nationally, or both. It changed regionally and nationally, so it's sort of a mess. I don't know if you're saying it's a mess. But it's not, what's not a mess is like the indications for someone needing a transplant. But then we have to deal with the other parts of it. All right. Great. I'm happy to answer more questions. I'll be outside later, okay?